This is going to be a video about explicit motor imagery or imagined movements, which can be used as part of a graded motor imagery program to drive cortical changes in patients with persistent low back pain. We'll discuss the theoretical underpinnings of explicit motor imagery, what movements to use, and optimal training dosage. Imagined movements are a progression from left-right judgment, during which the patient is subconsciously imagining moving their body, to the point where the patient is now consciously imagining moving their body. While left-right judgment training primarily activates the premotor cortex, imagined movements activate the primary motor cortex to a much greater extent, making it a logical treatment progression. Imagined movements have also shown the ability to activate lower motor neurons and even the muscles themselves to a small degree. Broadly speaking, there's two types of explicit motor imagery: visual motor imagery, in which the patient imagines watching themselves move, and kinesthetic motor imagery, in which the patient imagines feeling themselves move. As far as I know, there is no formal research investigating the efficacy of visual versus kinesthetic motor imagery for patients with persistent low back pain or other persistent pain conditions, and it might be beneficial to try a combination of both. There's a couple ways you could consider implementing imagined movement training. One way would be to use the Recognize app again. This time, instead of instructing the patient to discriminate between left and right images, instruct the patient to imagine performing the displayed movement. In this case, it makes sense to increase the image duration time so that the patient has more time to imagine each movement, perhaps 15 to 30 seconds for each image. It also makes sense to progress to context images as quickly as possible, as these images will likely be more functionally relevant for patients. Another method would be to prescribe videos for patients to watch while simultaneously imagining themselves performing the displayed movement. These videos can be progressed from small-range lumbar movements towards functional tasks. For example, the patient might begin by watching small-range lumbar movements such as pelvic tilting and left and right side glides. Then the patient could then progress to watching small movements into lumbar flexion, lumbar extension, rotation, and side bend, eventually progressing to full-range lumbar movements. From there, video prescription should be based on desired functional outcome. For example, if the patient wants to return to lifting tasks, they could watch videos of simple hip hinging movements and lunging movements, then progressing over time to more complex lifting tasks with heavier loads. Over time, we might also want to try varying the context that the patient practices in. For example, the patient can vary the position they adopt for imagery practice. Are they sitting, lying down, or standing? Or the patient might change the context they are imagining themselves moving in. Are they outside in their imagination, inside? Are they at work or at home? Are there any prominent smells or sounds in the imagery? And what is their emotional tone within the imagery? The patient can also play with the narrative perspective. Are they the one moving in the imagery, or are they watching someone else perform the movement? As with left-right judgment training, we are aiming to avoid pain during explicit motor imagery. This suggestion is based on the theoretical underpinnings of graded motor imagery training. If the task is too painful or difficult for the patient, try to modify the task. For example, we could try decreasing the complexity or the range of the imagined movement. Or we could use imagined movement training in conjunction with relaxation or mindfulness-based techniques. We could try changing the narrative context of the imagination. For example, visual motor imagery might be less painful than kinesthetic motor imagery, or it might be less painful for the patient to imagine someone else doing the movement. We might change the context of the imagery. For example, perhaps imagining doing the lumbar movements on a beautiful beach with warm wind blowing gently around you might alter the pain response. We should emphasize as part of a pain neuroscience education approach that it is very unlikely that any damage is occurring with the task. Emphasize messages of safety despite any soreness that may have occurred. Finally, we could consider regressing from explicit motor imagery to a bout of implicit motor imagery, otherwise known as left-right judgment. There's a lack of clear guidelines for optimal dosage of imagined movements. Most published studies using motor imagery for persistent low back pain have used a training dosage of about 20 minutes per day, split up into 1 to 3 training sessions per day. For example, a patient might watch a 7-minute video while simultaneously practicing the imagined movements 3 times a day. Studies investigating motor imagery for persistent low back pain have typically used a 2 to 3 week training period for imagined movements before moving on to movement-based therapy. In the absence of clear guidelines for optimal dosage of imagined movements, it makes sense to keep in mind the general principles of graded exposure. Aim to find a starting dosage that feels comfortable and doable for your patient. From there, aim to do a little more each day, but not too much more.